the other trial that has really come to the forefront in discussions in academic oncology practices in the United States is the ADAURA trial. And the ADAURA trial randomized patients who had completely resected lung cancer that were EGFR positive to receive standard of care or standard of care plus osimertinib. And so this trial has generated a lot of discussion, and I think going with our biomarker theme, this is one of the trials where these biomarkers that we often use in metastatic disease may also become important in patients with early stage disease where we treat them with curative intent. So with ADAURA, patients had lung cancer that was resected. That's standard of care. And then if they had the EGFR mutation, which in the metastatic setting is often sensitive to tyrosine kinase inhibitors or oral therapies that prevent certain mutations from being active and causing cancer cells to grow, they could either receive standard of care chemotherapy and observation, depending on their stage, or they would receive that same standard of care, but then afterwards receive 3 years of osimertinib. And the reason that this trial has generated so much discussion and so many different opinions on what to do is that it was an early report on the data. And so we don't have clear survival data, meaning adding in osimertinib would help patients live longer. What we have is a measure called disease-free survival, meaning in the patients who received the osimertinib for 3 years, those patients had reduced chances of recurrence of their lung cancer compared to the control group. The challenges are, in terms of interpreting this and how we take care of our patients, are twofold. One is previous trials have been done very similar to this with older generation EGFR inhibitors, and eventually the survival curves meet. And what that means is we don't help cure more patients by adding in those older generation TKIs. But on the same hand, some argue that the degree of disease-free survival is so significant that patients need to be presented with the data and have an opportunity with their physician to make an educated choice about whether or not they would like to do the osimertinib therapy. And so with this trial, in my mind, the way it's changed my clinical practice is that I have this type of discussion with patients with completely resected lung cancer who are EGFR positive, and we really talk about the pros and the cons, because right now we simply don't know whether or not this helps cure more patients with resectable lung cancer. Yes, and I wish that was the case. What we know about lung cancer is that it has a propensity to recur, even with excellent surgeries, not only taking out the tumors, but also taking out the lymph nodes in the middle of the chest. Unfortunately, lung cancer has a high likelihood of recurring. And so one of the main things that we talk about with patients is the use of adjuvant chemotherapy. That's been part of standard of care for lung cancers that are a little bit larger or involve lymph nodes in the chest. And that chemotherapy has been shown to provide a survival benefit after surgery, meaning that chemotherapy helps to kill the very small residual cells that just happen to be remaining even post-surgery. And the ADAURA trial is trying to add on to that, because even with surgery and chemotherapy, even with no evidence of disease, unfortunately, a large number of patients still have recurrence of their lung cancer. And the ADAURA trial is trying to improve those numbers even more by adding in specific therapies that target mutations certain patients can have. Yeah, no, that's a great way to put it. And what we see when we use this in the metastatic setting, so right now in the United States, osimertinib is the first line choice for patients newly diagnosed with metastatic EGFR positive adenocarcinoma, a type of non-small cell lung cancer. And while the vast majority of patients have a response to therapy, meaning the disease shrinks and is under control for some time, often years, eventually it does recur. So those cancer cells are able to find out ways to get around the suppression, the inhibition by osimertinib. There's a number of different mechanisms that are known, and sometimes there are mechanisms that we just can't identify, how the cancer cell was able to figure out how to avoid the effects of osimertinib. So it's possible that in the curative intent setting, where patients undergo the surgery, undergo chemotherapy if appropriate, and then do the osimertinib for 3 years, that if they do recur, one of the concerns is that their lung cancer might no longer be responsive to osimertinib because the cancer was able to determine a way around that therapy. Very much so. A lot of the oncogene-driven lung cancers, and EGFR mutations are one of them, have a propensity, or they often are found with brain metastases. So with the ADAURA trial, when patients did recur, there were fewer CNS, recurrences with the osimertinib, and that would also be a result that's expected, because what we know about osimertinib is that it's able to get into the tissue of the brain. It's able to penetrate something called the blood-brain barrier so that it can exert its anti-cancer effects in that area as well.